Comes from Baltimore, from Johns Hopkins University, where he's a professor of medicine and biomedical engineering and radiology. And he's been doing work on MRI for many, many years in many creative directions, among them MRI compatibility with implanted devices. And what interests us in particular is the attempts to reconstruct the substrate post-myocardial infarction associated with the scar that cause arrhythmias, and getting the structure with high resolution. So that's what he'll tell us about today. Henry is a physicist in his soul, like several of us here. He got his master's in physics from Berkeley before deciding that he wanted to be a physician. And in addition to all the other hobbies that he has, he also directs the CPR unit at Johns Hopkins Hospital. That's right.
Sure.
Yeah. Okay, so all you.
Okay. Does this work? Can everybody hear me?
Yes.
Anyway, thank you, Yoram, so much for inviting me. It's an amazing place you have here. And I think it is interesting to see kind of what electrocardiographic imaging, offers, and then anatomical imaging. So I'll obviously just be talking about anatomical imaging. And we've done a lot of work on, kind of imaging hearts, patients with arrhythmias. And I think, I think there's been a lot of progress made. We approach it from an anatomical as well as from a modeling point of view. So here's my disclosures, really nothing significant for this talk. So delayed enhancement MRI is becoming more and more important. And basically, you get very detailed imaging of scar and viable myocardium. And then the trick will be, as we go through this, to figure out what imaging parameters, what imaging characteristics actually give you insights as to how arrhythmogenic a particular part of myocardium is, and then how much is it really participating in the arrhythmia circuit. So here we just see some work from Ray Kim and others who've really pioneered this cardiac delayed enhancement MRI, and we actually see MRI images on this side and then the corresponding TTC images here. And these obviously are dead hearts. I mean, you get really good MRs, in patients with, if the hearts are not moving, because motion is a real problem with MR, although the technology is advancing so much that even that's becoming less of a limitation as time goes on. But you see these delayed enhancement imaging on the MR is surprisingly close to what the TTC shows, really on both of these. So with gadolinium contrast, you get really good images. It's really been extensively validated, and it can have high spatial resolution depending on how clever you are in terms of your MR pulse sequences and breath holding and gating and things like that. So first we looked at non-ischemic cardiomyopathy, and scar can be present and is likely the substrate for VT. Oops. So this was a study done by Saman Nazarian in our lab, where we looked at patients who had documented non-ischemic cardiomyopathy. There were 26 patients, and they had gadolinium-enhanced MRI, and then the scar transmurality was calculated for each sector. The idea was, we prospectively wanted to see if, in fact, there were imaging parameters that suggested who was at risk for ventricular tachycardia, and then what in the images told you that this, in fact, was the case. So basically, the heart was chopped up into different sectors, and these lines were drawn through the heart, and then we looked to see how much of it was normal myocardium, which is shown in black, and then scar, which is shown in white. And so there were a number of different scar patterns that were noted in these 26 patients. They all had documented no coronary disease in the cath. So some of the patients actually had no scar, and it was thought before this, really, and before some studies like this, that that non-ischemic cardiomyopathy really had very little scar. So we just wanted to see, in fact, what was going on. So a lot of the patients, in truth, had no scar, but some of them had this kind of mid-wall scar pattern, which actually had been noted in the distant past. And we're calling this a 1 to 25% of the transmurality that the scar takes up. And then other patients, had a little more scar, like this would be 26 to 75% of the transmural extent of the wall. with scar was present. And then others, had a lot more scar where it was actually pretty much transmural scar, which is actually kind of shown kind of in this area over here. And again, these are just cross sections through the hearts, and multiple cross sections were looked, with the left ventricle and the right ventricle. And so then what we found is that in fact, some of these patients were inducible for ventricular tachycardia and some of them were not. And there were 7 different morphologies of sustained ventricular tachycardia induced in these 5 patients. And the mean cycle length was pretty fast, about 200 beats per minute. And what we did is we looked at all patients, and those that were inducible and those that were non-inducible. And the ejection fraction, endostaltic volume, left ventricular mass, patients with scar, and scar volume, you would have thought that the scar volumes could have separated out the patients who were inducible from the patients that were non-inducible. But interestingly, there was a trend, but it did not reach statistical significance. Potentially, if you had more patients, in fact, the scar volume would have. But it didn't in this case. But in fact, if the predominant scar distribution involved only 26 to 75% of the wall thickness, in fact, there was a very strong separation, even with these very small numbers, in terms of patients who were inducible and patients who were non-inducible. So that's fine. I mean, that says, okay, some kind of scar in some distribution in the heart maybe allows VT to occur. It doesn't prove, in fact, that that's the cause of the VT or the critical thing that's actually allowing the VT to occur. But then the study by Cho et al. A little later, they had 79 patients. They did not have ICDs, and they had very compromised left ventricular function, with an EF just in the, below 30%. And they looked at patients that had focal patchy delayed enhancement, which really wasn't a lot of it, and then patients that had diffuse myocardial delayed enhancement. And we see on this vertical axis, event-free survival over a follow-up period of a little over 3 years. And interestingly, the patients with very little scar, or just focal patchy delayed enhancement, actually did quite well. But the patients, in fact, that had this diffuse myocardial delayed enhancement actually didn't do so well at all. So, I mean, it's a nice follow-on to the notion that, in fact, a certain amount of scar in a certain distribution in these non-ischemic cardiomyopathy patients is associated not only with inducibility of ventricular tachycardia, but in fact, bad outcomes. It doesn't prove causality, but there's this very strong suggestion that in fact that scar really is involved in the ventricular tachycardia. So with ischemic cardiomyopathy, it's completely different. Because hyperenhancement generally does not have uniform intensity over all of the hyperenhanced area. And maybe a lot of you have heard this notion of the gray zone. Because in ischemic cardiomyopathy, there's an intermediate level of hyperenhancement that often occurs. This is from Schmidt and Kathy Wu and Joel Lima that was done at Hopkins. And here's a typical image that you see, because basically here's the left ventricle, the right ventricle, and this kind of black stuff is the normal moving tissue. It's probably normal tissue. But then look at this other tissue that hyperenhances. What you see is this white area that's hyperenhanced a lot, and that's typically histologically been shown to be just dense scar. But what you can see, and I hope I'm not really leading you too much, if you look at this area here, which is still part of the left ventricular wall, but in fact it looks gray. It's not black and it's not white, it really looks gray. And that's really where this whole gray zone notion came from. And histologically, it's probably a mixture of normal looking tissue and then scar. And I'll show you some slides later on where we refer to this as kind of a heterogeneous zone. But in fact, yes?
Did you quantitate the scar in the longitudinal dimension also, or just transverse?
So this analysis is typically done just in cross sections. And you could do it either way. I don't think there's any reason why one way would be better than the other. But classically, it's been done, because then we do stacks of them and build 3D reconstructions. So basically, there's a lot of different ways of quantifying this gray zone. This one uses a signal intensity cutoff value. So basically, the signal intensity is high enough, you figure that's scar, and that's colorized in red, and then kind of intermediate between this kind of black and the white here is this yellow area, which then is quantified as the gray zone. So what they did, again, they did the whole inducibility thing. So it turns out the extent of the gray zone predicts inducibility. Again, we're getting at what are the things on the imaging that predicts inducibility, to suggest, in fact, that those things then are causal. Doesn't prove it's causal, but I think hopefully I can prove to you causality as we go through this, because we've been very interested in that. So here we have non-inducible and inducible patients, and again we look at all of the left ventricular parameters, end-diastolic volume, et cetera, infarct location, and in this case transmurality. In this they found that in fact the degree of transmurality, different from what we found for the non-ischemic cardiomyopathies, it did not predict inducibility in the ischemic cardiomyopathies. But interestingly, the amount of hyperenhancement, like the infarct core, this kind of dense scar portion, this kind of very white part, was no different between the patients that were inducible and the patients that were not. And even the infarct size was not statistically different between the patients that were non-inducible and the patients that were inducible. But in fact, the extent of the gray zone had an enormous separation between those that were non-inducible and those that were inducible. Now, other investigators have found, in fact, that the amount of scar is important. But in this particular study, I mean, it was a small study, 47 patients. It found that, in fact, the extent of the gray zone was the most important factor. But again, is inducibility, does it mean anything in terms of risk and having events? And it looks like the answer to that question is yes, because this was a study done by Bill Stevenson and colleagues, where they looked at 144 patients with coronary disease. They did not have ICDs because they were not candidates for ICDs at the time, because they had ejection fractions, that were, only moderately reduced, slightly reduced, and that they looked at survival versus a follow-up period of up to 5 years. And they looked at a quantity, they called it myocardial delayed enhancement at the periphery, which is basically the gray zone. And so if it was less than the 50th percentile of all the patients, those patients actually did quite well over 5 years. But in fact, if the gray zone or myocardial delayed enhancement in the periphery was greater than the 50th percentile, they did much, much worse. So in fact, this gray zone not only predicts inducibility of ventricular tachycardia, but it also predicts absolute survival. So it suggests, but doesn't prove, that in fact this gray zone or heterogeneous area is in fact the substrate for these arrhythmias that they get. So what is the gray zone? I mean, that's the next obvious question. So a lot of hearts from humans were really not available. So, and in fact, we wanted to do some more detailed electrophysiology. So we came up with this 10-week swine infarct model, where basically what we do is we blow up a balloon in pretty much the mid-LAD in swine and leave the balloon blown up for about 2.5 hours, and then deflate the balloon, and they get a nice infarct from that. So this was this work done by Heidi Essner in our lab, and basically, here's two representative hearts. One, this heart was non-inducible, this heart was inducible. And so what we see in the non-inducible heart is, the normal tissue, is fairly uniform. And then you have this hyper-enhanced area, which has been thinned dramatically after this 10 plus, it's really 10 plus weeks. It's really 10 to 20 weeks. But it's actually pretty uniform. It's just this nice white area. And so this animal was not inducible, and 9 of the 17 animals were not inducible, and they had a gray zone that was about 12% of the infarct. And then on the inducible animal, again, I don't think I have to lead you too much. Here's kind of the normal looking tissue here, but we look at the kind of the infarct area, and it really is heterogeneous. I mean, there's some very dense scar there. There's some kind of almost normal looking tissue. There's a lot of gray area there, and it's very heterogeneous. And in fact, you could almost imagine, VT circuits kind of oozing their way through this kind of gray area. And, if this works out, then this would be ideal targets for, VT ablation. You just see these areas and bam, you navigate your catheter there and you're done. But anyway, in these inducible pigs, so 8 out of 17 were inducible, and their gray zone, was almost twice the size on average as the non-inducible animals. So again, all gray zones are not created equal. We probably don't have to destroy all the gray zone. In fact, humans often have a lot, but we're looking at ways of trying to figure out which gray zones are important and which are not. So then, again, inducible versus non-inducible animals, they looked at all the ejection fraction, mass, and again, and only really the gray zone separated the inducible from the non-inducible animals. So then we did, at the end of these experiments, we did very high resolution MR imaging. And these obviously are ex vivo, non-moving hearts. You can't get this kind of resolution in vivo yet. So these were 0.4 millimeter isotropic voxels, which is really kind of CT scan levels of resolution. And these are three-dimensional reconstructions, again, in typical inducible heart, typical non-inducible heart. So the gray is colorized, is the normal-looking tissue, and then the red is the scar. And here we see cross-section, or a kind of more longitudinal, kind of a funny view here. But anyway, so you see the kind of the normal-looking tissue, and you see the scar in white, and then the scar is colorized in red, just to show it a little better. And I think what strikes you immediately is, and in fact, in the inducible animals, you see lots of islands of kind of this kind of normal-looking tissue mixed in with the scar. And in fact, it shows up very nicely, on the MR section, where you see an amazing amount of tissue heterogeneity in here. There's scar and kind of normal-looking tissue that are all mixed together. You see it very nicely on the colorized sections, slices. But in the non-inducible, there's amazingly little of this. There's very little of this kind of normal-looking tissue. Yeah.
I'm just wondering how when you define gray zone, is that a standard based on what intensity you see in scar versus healthy tissue? Is it like,
So
twice the
that's a
intensity
great
or
question.
something?
There's actually no standard. There's at least
you
there's
can
at
alter
least
that.
4. Right. So what
And
we
it
do,
would change
what we
considerably.
do, our particular definition is we usually use 2 or 3 standard deviations above the dark part is the gray zone, and then some more standard deviations above that. It's usually 2 or 3 standard deviations above the gray part is the white part, and the stuff in between is the gray zone. There's lots of different ways. You can have absolute intensity cutoffs. And it turns out that Tim Dickfeld, actually one of our former fellows, is at Maryland now, has actually looked at this in detail about how can you define the gray zone most accurately. And it turns out all of the published ways with using standard deviations or using absolute intensities give actually surprisingly different results.
Yeah, because if you change your cutoffs,
Exactly.
you can make one look exactly like the other.
Well,
or very
yes,
closely.
So what we do, so the way we've done it is kind of in between all that. We use an intensity level, but what we do is we look at the images, because you can actually see the gray zone with your eye.
Mm-hmm.
And so if in fact the gray zone, if the computer quantifies it the way we think it should be, then we accept it. Sometimes it's just completely off. But in fact, it's like interpreting a lot of different things. There's a little bit of fuzziness in this. But I think that, some things are ambiguous, a little bit ambiguous. But I think if you use consistent criteria, it's probably okay. But anyway, we found an intensity-based algorithm that seems to be consistent with what we see, like on the images. And in fact, there's really no doubt that this is heterogeneous. And because this has there's no calculations here. I'll show you some calculations as you go on, and you can decide for yourself how close they are. But this is clearly way more homogeneous than this. But that is an ongoing issue as to how to best to quantify this gray zone. So then what do these images tell us about the mechanisms of VT? We see all these pretty pictures, we see some gray zone, but how close is it really correlated with anything? So this is some work done by Hiroshi Ashikaga a couple of years ago, where what he did is, again, he did this infarct model, the swine infarct model, and he actually put a 128 electrode epicardial sock. And then again, after about 10, 20 weeks, induced VT, pacing from the various electrodes on the sock, and then looking at the VTs that were induced. And there's a lot more than 128 points on here because he actually did bipoles, and, from neighboring, and that's where there's a lot more recording points here. But anyway, so this is a typical example of a VT that was induced. We're basically going from A to B to C to D to E, and the tail meets the head right here. So this is probably the critical slow conduction area here. And you can see this very nice progression around this VT circuit of these R waves as they zip around. And then the next thing, the hearts were actually explanted, and then all the electrode sites were actually digitized with a 3D digitizing thing. And then the scar areas were then superimposed on the electrical information. You see this scar here that's been registered to the electrical information, and then you saw that nice little kind of figure of 8. It was kind of, one side was zipping around this way, the other side was zipping around that way. And the VT actually seemed to be going right through the middle of the scar. And then what you do is if you look at then the detailed high-resolution MR image of this scar, which we got, you can see in fact that it's very heterogeneous there. There's scar there, but it's actually mixed in with a lot of normal-looking tissue there. So it suggests in fact that the VT is going right through this kind of heterogeneous area. And then interestingly, there could be as many as 5 to 7 different VTs in each heart. And then if you went through that same analysis, what you could find, in fact, that one heart, one scar, could actually have a number of different pathways through and on the edges of the scar. Suggesting, in fact, that multiple morphologies of VT can take different pathways through and around the scar. So then the question is this gray or heterogeneous zone identified on MR the critical pathway for VT generation? Because we've seen a nice association. I think it's hard to deny that there certainly is a nice association between the presence of scar, the presence of gray zone, and VT inducibility. But is it really the critical pathway? So, so basically we're looking at is there a causal role for this gray zone? So the heterogeneity is associated with inducibility and combined events in patients. That's very clear. Despite this association, in the past there's been no causal evidence the gray zone detected by imaging causes life-threatening arrhythmias. Maybe it just happens to be there. Maybe people are going to get these arrhythmias anyway, and the scars just happens to be there. So then we hypothesize that the gray zones are mixtures of scar and viable tissue and are the critical areas of VT generation, and that successful ablation of ventricular tachycardia would include ablation in the gray zone. How much of the gray zone has to be ablated remains to be determined, and that incomplete ablation of the gray zone would result in recurrent VT since the substrate for VT is still present. And in fact, right now the success rate for ablating VT, depending on the patients and what have you, might be 60 to 80%. But the recurrence rate is enormous. It's probably 50% at least. So is the scar evolving, or are we just doing incomplete ablations? I mean, if we really understood the substrate, obviously we could probably do better ablations and better risk stratification. So then these are 16 of the swine from that study. So half were inducible, half were non-inducible. And anyway, here we're starting to get into this whole quantification of the gray zone.
I just had a quick question.
Sure.
As far as quantifying heterogeneity, are there any more, benchmarks for how heterogeneous? In other words, yes, you have a gray zone, but
Like what is heterogeneity?
Well, just in other words, so you see it.
Like how many?
You see it's gray, but
Yeah.
the thing is there has anybody documented looking at the grayness and tissue what correlates with how. I mean,
So if you look at it histologically, what you see in normal myocytes in the normal area, if you look at the dense core of the infarct, it's typically just collagen.
Right.
And if you look at this gray zone, it's typically there are some normal-looking myocytes,
Right.
some scar. I mean, DeBacher years ago did this in great detail, where they did these very serial sections through there, and you actually find viable-looking myocytes interspersed in the scar.
But there's no scale of what gray and heterogeneous, you know, and
Like how gray is gray?
how gray is
Or how many cells does it
Gray,
take? Yeah, I think that's still an evolving kind of thing. So what we did in these is, so again, the normal parts, again, these are all cross-section, you know, LV, RV. And, you know, they're all LAD infarcts, which involve a lot of the septum. So we see the normal-looking tissue in this kind of, you know, grayish area. In this case, some of them are black, just depends on the contrast. But then the dense scar portion, you know, shows up in red, and then this gray area, again by our signal intensity kind of analysis, shows up in green. And you can see that, in fact, in these animals, the animals that were inducible, using similar criteria for gray zone on this side as well as on this side, there's a lot more of this kind of green or gray zone area in the animals that were inducible than the animals that were not. And I showed you on a previous slide, in fact, that the gray zone, the total extent of the gray zone, was about twice as great in the inducible animals as in the non-inducible animals. And then we did conventional mapping of the VT. Again, each of these inducible animals had anywhere from 3 to about 6 VTs that were inducible. And so this just shows, you know, places where we did some kind of standard substrate mapping, and we did pace mapping in this particular animal, basically going across here. And there's one VT which we see here. And, you know, for the electrophysiologists in the audience, you know, here's a couple pace maps close to it. And in fact, this pace map, it's not 12 for 12, but it's pretty close. I mean, it's pretty close. Usually in the pigs, we get 10 or 11 for 12, and that would be the best site. And then, you know, very close to it, actually only a couple centimeters away, we had another VT pace map, which actually a completely different axis from VT1. Because you can see that in lead 1, this goes up, in lead 1, this goes down. So these are completely different axes. And, you know, and then this pace map looks very close to this VT, and it's right there, and the other pace map is right here. This suggests that this VT is coming from this area, this VT is coming from that area. So why do we do it? So the reason we did all that is we would then ablate at these, you know, pace map or entrainment mapped areas that we found these VTs to be coming from, and then see where, in fact, the ablations were in relation to the gray zone. Because in this particular study, we didn't want to do an image-guided ablation first, because we figured, okay, if we wiped out the gray zone, we don't know where we would have ablated for a regular ablation. So we wanted to see where would us and our EP colleagues put their ablations in this kind of a situation, kind of using standard electrophysiologic guiding principles, and then where were those ablations in relation to this gray zone? In fact, was it necessary to wipe out the gray zone to get rid of the VTs or not? So here's one example here. So here's here's an animal showing the dense scar. So here we see that, again, a cross section LV RV. Here's kind of the normal looking tissue. Then here's the scar, and then here's this kind of gray zone area here. And I think this probably, even to your eye, probably looks a little grayer in this area than it does over here. And then here's the colorized images where the red is the dense scar and the gray zone is colorized in green. And this just shows on the carta where it is. I won't go into this detail. But what we see on this particular image over here is we see again the dense scar, and then we see the ablations that were done. And these were blinded. These were actually blinded to the MR images. But yet you see these, you know, the 3 different ablations kind of right in this gray zone area. I mean, I don't know that you could have done a better job of finding that. In fact, if you knew that that's where you wanted to ablate. And then, so that particular animal was non-inducible after the procedure, but was inducible a week later. This particular animal, again, we see a lot of gray area here. We see normal tissue. We see the dense scar. So there's before ablation. And then, you know, the gray zone, you know, it's very consistent visually. I mean, this is kind of heterogeneous here. The computer says that's the gray zone there. And then, again, ablating without image guidance. This was no image guidance at all in terms of the gray zone. In fact, you know, this this whole area now is destroyed. I mean, you know, it's just all scar. And this acutely, or actually this isn't scar yet, this is just the destroyed tissue. And in fact, these dark areas here are not tissue that was missed. They're actually steam pops. You know, there's no tissue there, so you can't hyper-enhance when there's no tissue there. Actually, another potential advantage of MRI is you can actually do thermography with that, but I really won't get into that. So anyway, you see that whole gray zone, if you look at this image compared to this image, this whole area of heterogeneity was destroyed in this. And again, this was using standard electrophysiologic criteria. And then a week later, it pretty much looked the same. Some of the edema had resolved, but again, the whole gray zone is gone. And again, this is just an area, this was just a crater right there. And this animal was non-inducible chronically. Again, it doesn't prove it really. Well, maybe it does, because inducibility, you can always argue whether maybe it's just not inducible because it wasn't inducible. But then what's even more interesting to me at least is that incomplete ablation of the gray zone resulted in inducible VT. Because here's an animal where we did this standard EP guided ablation. Acutely, the animal was non-inducible, but in fact, none of the ablation was actually done in the gray zone. But then a week later, the animal was eminently inducible. And look what's left, okay? So now you see the standard resolution MR, we see this kind of normal tissue, we see this very heterogeneous infarct. And then on high-res MRI, you can see, in fact, there's enormous amounts of heterogeneity with this scar and white, and you know, there's interspersed with this kind of normal-looking tissue. So in fact, if we believe that this heterogeneous area really is the substrate for VT, we would expect, in fact, this animal to be inducible, which it was. So then, again, it doesn't prove things because we didn't have enough N for that. So then what we wanted to do was then see, can you explain everything in a model of this VT generation from this heterogeneous area? Because that would give a little more kind of emphasis of the idea that, in fact, that really is the substrate for the ventricular tachycardia. So basically, can the VT circuits be predicted strictly on this kind of anatomical distribution of scar? So this is work done in collaboration with Natalia Trainova. And you know, here's the anatomy of the computational model. Basically, we take these MR images. You know, here's again LV, RV. Here's scar here. You know, here's a kind of a long axis. You know, with the LV here, and you see all these white rims of scar. And here's another view where we see these white rims of scar. You know, endocardial scar, typical kind of coronary artery disease pattern. And then it's segmented. The normal tissue and the dense scar in the gray zone is segmented, and there's a three-dimensional reconstruction. All the cross sections are stacked up. Then then it's loaded into a finite element mesh, and then actually myofiber orientation is actually even put into the model. And this is not from diffusion tensor MR on this particular heart. Basically, there's the diffusion tensor MR, which gives you fiber orientation, fiber direction, was done on kind of standard hearts, and then they were morphed onto this. So, and it seems to work surprisingly well, but again, it's a kind of a standard morphing process, and it's a potential limitation of this modeling approach. And then for the computational simulation, again, kind of the 10 Tusher type model, and you know, Dr. Rudy's model was used as well, where you know, the normal tissue is segmented in red, the scar is segmented here in yellow, and then the gray zone, if you will, is this blue part here. And so you know, there's an ionic model. The signal intensity, again, is we say, tells you what the tissue properties are, at least for modeling purposes. So the scar is yellow, it's an insulator with no conduction at all. And in this case, the signal intensity was greater than 50% of the maximum signal intensity. The heterogeneous zone in blue we assigned intermediate conductivity, and again, these are the numbers they used. And in this, the signal intensity was less than 50% of the max, and greater and greater than the signal intensity of the remote myocardium. And then the non-infarcted myocardium, which was colorized in red here, basically was given normal conductivity. And there was, you know, a Linux cluster and simulated surface ECG, and they were blinded to the ablation results. And you could say, well, what if you use different values for these ionic currents and different values for the conductivity? Would it make a difference? And interestingly, it seems to make amazingly little difference. In terms of the sensitivity of the model to all these different parameters, it's surprisingly little. Again, I haven't done the models, but they tell me that it's very insensitive to these changes here. And then, so first, you know, we looked at, I showed you this already. So we took this, you know, this kind of figure of 8 VT that we see zipping around like that through this scar, and then we did we loaded this anatomical information into the model, again with the segmented gray zone, and there you go. Too quick on the trigger. So we pace, and then there's your figure of 8 VT. There's one limb of it, and there's the other limb of it. So I mean, it looks surprisingly similar, in fact, to the VT from the real heart. And then that last pig I showed you, the one that was still inducible, they did a lot of modeling work on that. Again, here's the pre-ablation MRI. And then again, they colorized the normal tissue in red, the scar in yellow, and then they call it the peri-infarct zone, our gray zone in green. And then they load it into the finite element model. And then it makes really pretty pictures. I mean, it's really nice, pretty pictures. But anyway, there's the VT. You can see spreading all over. And then this, it turns out in that particular animal, for whatever reason, we really missed. Because you see this kind of area right here. So here's the, you know, kind of the cross-section. There's the lateral wall. There's the septum there. There's the right ventricle there. And here's this kind of funny-looking area here. You see this kind of white rim here, which looks surprisingly similar to this area over here. So this is our big ablation. And these were, you know, cooled RF ablation, made a big lesion there. And for whatever reason, the animal was non-inducible acutely, but chronically it was very inducible. You see, we were nowhere near the gray zone on this one. And in fact, you know, and there's the experimental ablation site, loaded into the finite element model. And then there's we pace, and then there's the VT then coming around and circling around. So this, in fact, the model actually, using the same anatomical information, putting the ablation where we ablated, says that you missed. In fact, the animal's still going to be inducible. So the simulation predicted the failure of the ablation to terminate the VT. And then the next logical step is to ask the model, okay, where should I ablate? Has some clinical implications. So the model says to ablate right there. If I ablate over there as opposed to over there, it will get rid of the VT. So we segment it out, and then now we pace. There's one return cycle, and then it stops on its own. This suggests, in fact, that if I had ablated in this area right here, which is very heterogeneous, I mean, you don't need a computer to tell you this is really heterogeneous over here. I mean, that's pretty odd. And it said to ablate right there, and the VT's gone. So this, you know, if this really works out, it could be an amazing therapeutic tool. But I think it suggests pretty strongly that, in fact, that particular area is critical for generation of that VT. So the simulation predicted the optimal ablation target. So we actually have done a bunch of patients using the same kinds of things. And then here we see, you know, here's again a cross-section, longitudinal section. This is a patient with kind of an infrabasilar scar, and there was gray zone in here. And in fact, this VT, you can actually see it coming up kind of the infrabasilar wall right here and spreading out one limb here and one limb here. So So again, one limb here, one limb here. It shows on the cartoon this kind of figure of 8 VT coming around there and around there. And then you say, well, okay, is that really where the VT is? And so basically, here's some more information. So the clinical and the simulated ECGs are very similar. It almost looks like this is low-pass filtered, but it's not too bad. And then, but the real thing was the success site for ablating this, not knowing what the images looked like, was in fact right in this isthmus, if you will, right here. The basilar inferior wall was a success site for the ablation. So again, it's just another patient. You know, and in this case, this scar is kind of more posterior. You see this white rim here, and then, you know, it's kind of, you know, on this kind of posterior area over here. And then in this particular one, you can see the VT coming kind of down this kind of posterior wall here. And again, in figure 8, one limb going that way, another limb going that way. And again, we see on the cartoon, one limb going that way, one limb going that way. And again, the clinical and simulated VTs, at least in that 1 lead, are pretty similar. And the success site for the ablation was in the posterior wall. Again, these were blinded to the simulation results. And just one last one on this, which was a little more complicated. Because on this one, what we see is we see this kind of septal, kind of heterogeneous area. And these are, you know, real patient MRIs. And we see this kind of dense scar and this kind of heterogeneous area. But then there's a whole separate one, kind of more on the lateral wall over here. And there were 2 separate VTs in this patient and 2 separate success sites. You know, one related to this scar and one related to this scar. And this one, we see this kind of more septal one, where we see this kind of more complex figure of 8. You can kind of see it coming down and going around, coming down and going around, and the cartoon shows it. And again, at least for this VT, the simulated clinical ECGs are close, and the success site for this one was, you know, was on the septum, kind of right along this area right here. So again, that just gives a little more information. In fact, you can explain these VTs. You can explain extinguishing the VT strictly on anatomical grounds, assuming you've assigned the right electrophysiologic properties to these different anatomical substrates. And then just to, you know, a little bit some other things, just to kind of move along. So with sarcoidosis, this substrate imaging probably can be very helpful as well. So this is a study done by Ray Kim and others, where they looked at patients that had documented pulmonary sarcoidosis, and which I think, you know, 75+% of patients that have cardiac sarcoid have pulmonary sarcoid, and they just did imaging on them. And you can see a lot of different patterns. I mean, here's the MR images, shows the scar. They actually have these cartoons to show you where the scar is. And there's some that are endocardial scar, there's some that are transmural scar, see the white all the way through. There's some that are mid-wall scar, kind of like the non-ischemic cardiomyopathies. There's some that are, you know, epicardial scar, you know, more like non-ischemics, and some are kind of mixed. And what they found was the areas of, you know, this hyper-enhancement. This is a patient that unfortunately died. And in fact, you see these kind of, you know, the sarcoid non-caseating granulomas in this area of hyperintensity. And in fact, the outcomes were very predicted by this delayed enhancement. Because here we see event-free survival with follow-up duration, and then cardiac survival with follow-up. And if they had no delayed enhancement, probably didn't have cardiac sarcoid, they did quite well. And if they did have delayed enhancement with probably definitely had cardiac sarcoid, they actually did much worse. And there was a couple of patients where biopsies of the septum were negative, but yet they had a lot of delayed enhancement. They probably did have cardiac sarcoid. And in fact, the MR may actually be useful for telling you where to biopsy. Because in fact, if the septum is not affected, and you biopsy the septum, you're going to miss. You know, if you biopsy an area that has delayed enhancement, you have a much more likely hood of finding an area that actually is affected. And then just lastly, a few things about atrial fibrillation, because I mean that's really a hot topic these days. I mean, you know, the Utah group has done a lot of work with scar imaging and atrial fibrillation, more from, I think, a prognostic point of view as much as anything else. But what they found, and they're actually one of the few labs around the world that report these kinds of findings. You know, some people have kind of reproduced them, other people have had more difficulty in reproducing this. But basically, it's some interesting data. They find a number, I think there's actually 4 different classifications. Now, this, here's a left atrium with a pulmonary vein sticking out. And the blue is kind of what they consider to be normal tissue, and then the green is colorized to scar. And you know, there's mild, there's moderate, and extensive. Interestingly, the mild amounts of scar, if you look at patients in sinus rhythm over about a year and a half, the patients with very mild scar pre-ablation and then have an AFib ablation tend to stay in sinus rhythm, where the patients with the most extensive scar pre-ablation and then have an ablation tend to go back into atrial fibrillation. It suggests, in fact, that the presence of scar may be a substrate, if you will, for atrial fibrillation, at least sustaining. So then, you know, Natalia and company modeled that as well in the atrium. So the computational model predicting AFib. And so they had some human hearts that they were able to get images on, at least. And you know, here's the MR geometry and fiber orientation, and highly processed, obviously. And then from a modeling point of view, they took these hearts and actually put a simulated catheter near this pulmonary vein, and they could not induce atrial fibrillation. They just had, basically, these were simulated, and these were actually real, from the real patient electrograms. And anyway, so they could not induce AFib in this patient that actually had very little scar. Okay, and then the ones where there was, they actually then put, I think, 3 times the amount of scar, like a lot of scar, in kind of a heterogeneous pattern in this area. And then they did a little bit of pacing in the pulmonary vein, and in fact got atrial fibrillation to sustain in this kind of anisotropic. Again, suggesting that you can explain atrial fibrillation sustaining just by having anisotropy of scar and enough scar in the atrium, which is entirely consistent, in fact, with Marush's data. So there are certain limitations to MRI scar imaging. There's motion effects, there's partial volume effects, there's artifacts from the ICD, and there's the fact that they actually have an ICD at all, and then there's this nephrogenic systemic fibrosis. So motion can reduce resolution. I kind of made a light of the fact that, you know, non-moving hearts give the best MR images. And in fact, there's a lot of work being done by a lot of people who are actually doing motion correction. And I think the MR images are getting to be improved dramatically. Here's the heart without motion correction. And this was done by L.A. McVeigh actually almost a decade ago. But they did some fairly simple motion correction and actually got much, much better images. These are even improving a lot today. So then partial volume effects. So this is really where the gray zone area really becomes grayer. Because in fact, what can happen is that here's a anatomical, you know, the pathology showing the scar with very fine fingers of scar mixed in with the kind of normal-looking tissue here. And with this 3 Tesla very thin slices, you actually see this with exquisite detail. But in the 1.5 Tesla with 8 millimeter slices, you actually see a lot of this area looks gray. And in fact, this would be the heterogeneous zone. So in fact, all it's doing probably is smearing it out and making it look kind of more uniform, but still gray. Still, the signal intensity here is less than it is here. So in fact, it's probably giving us a true depiction of the gray zone, just not with quite the accuracy that you'd see in these finer images. And then artifacts from ICD can mimic hyper-enhancement. And I know most centers now can't do imaging in patients with ICDs at all. So we do. So here's a patient. The ICD obviously is here, because normally the chest should go up like that. That's the artifact from the ICD. And in fact, this area here in the heart, this kind of white area, looks like hyper-enhancement, but it's not. And this area here looks like hyper-enhancement, but it's actually not. And if you look at other views, the hyper-enhancement kind of disappears. But in fact, there are ways, this is only a problem in really about 20 or 30% of patients. Most patients with ICDs, in fact, the cardiac exams look fine. So in fact, imaging can be safe with an ICD. We've actually done over 1,000 MR examinations in over 750 patients, and with no significant problems at all. And about half of these were ICDs, so you certainly can do it. We have used a special protocol. There have been no adverse events. There have been no clinically significant changes in pacing parameters. And we get adequate scar imaging in about 60 to 80% of patients. And interestingly, there are some interesting MR physics that allows you to get rid of this artifact, but that's still under development. So this is, and as time goes on, the FDA prohibition, if you will, or at least the contraindication that's there now probably will disappear, because the companies are really seeing that MR imaging is becoming more and more important, and they would, and the companies are coming out with MRI conditional devices. And then finally, the worst thing is nephrogenic systemic fibrosis. It's a scleroderma-like syndrome. It develops in patients with severe renal disease. They're generally on dialysis. It's very rare. It's not reportable. It's not reversible. It was first reported in 2000, but yet delayed enhancement MR was done well before 2000. So why did it start in 2000? Unknown. It was linked to gadolinium use in 2006. The mechanisms are unknown, and luckily it does not occur in patients with a GFR greater than 30. So then in summary, a delayed enhancement MRI can accurately identify detailed anatomy of the scar. Multiple VT circuits can exist through and around areas of scar. Scar transmurality distribution appears to be related to arrhythmogenic potential in non-ischemic cardiomyopathy. The critical zones for occurrence of VT in ischemic cardiomyopathy are likely areas of tissue heterogeneity, often called the gray zone, that can be imaged with MRI. A delayed enhancement MRI may be very useful in diagnosing cardiac sarcoidosis and may predict the propensity to arrhythmias in those patients. And the limitations include motion effects, partial volume effects, and the presence of an ICD. And I'd like to thank the army of investigators that really made all the work possible that came from our lab. So thank you very much for your attention. I'll be happy to answer any questions.
Okay, questions?
Yeah.
You mentioned in cardiac sarcoidosis that you use delayed enhancement. What is the radio tracer that you use? Is it gadolinium?
It's still the same gadolinium.
Because the Japanese use a different tracer, the name of which I can't remember, but something we don't have on standard protocol at Mallinckrodt. They have a separate guideline and a diagnostic criteria.
So are they may be doing gallium scans?
Yeah, perhaps gallium.
Yeah, I think they're doing gallium scans.
But for somehow they found that is a better predictor.
So I know that Japan, there's this Japan criteria
Yes.
for sarcoid. And I think it includes gallium scanning. I think MR actually is better because the resolution is better, way better on MR than gallium scanning.
Gallium, that's a nuclear medicine. You're talking about nuclear medicine.
Yeah.
And gallium has been, I guess, I would be surprised that it wouldn't have been be offered at Mallinckrodt. That when I was a resident, that was the traditional way that you imaged sarcoid. It's sort of considered passé. I mean, you know what I'm saying? Other you look for they call it the lambda and the panda sign.
Yes,
you
yes.
Look for the
Yeah. So Ben Barsline and I were talking about this, and he said it's not actually offered anymore. It's not even available. Because it's part of the Japanese criteria. I think they're probably kind of more forward on diagnostic criteria for cardiac sarcoidosis than we are. Or at least
right. Well, there are these published Japan criteria which don't include this kind of imaging.
Correct.
And I think I think MR imaging is going to take over for sarcoid because it really seems to find the actual areas that are affected with much better resolution than the gallium would be.
I think actually because of the ICD limitations.
Yeah,
some of these
Well, I
patients
guess at our institution it's not really a limitation, but I guess for everywhere else it is, or it doesn't have to be. I mean, I'd be happy to talk to your IRB about the safety of doing it, because again, it turns out that the technology that's in implanted devices now to make them I have a whole nother talk on that, but to make them kind of EMI safe, because there's all kinds of electromagnetic interference, from microwave ovens, cell phones mainly. It turns out a lot of the things that went into that, plus more modern ICDs are smaller, they have less ferromagnetic materials and much better EMI protection than older devices did. In fact, if MR scanners came out today, this wouldn't be an issue.
And my guess is it's not the IRB that it's really the hospital. In other words, I think that if you had a consent form, and you went ahead and consented somebody and listed the risks, that you could probably go ahead with it.
Yeah, well, it's really all a risk benefit, because the patients don't explode, the devices don't get ripped out. In fact, they're completely unaware that the device is there when there's very little magnetic material in them. There's like we measured all this, and there's 50 grams of force on the device. It's 2 stationary golf balls weigh about 50 grams. So that's how much force is exerted by the magnetic field on the device. And the heating of the leads is really probably trivial, because all the EMI protection that's been built into the devices pretty much makes them MRI safe. Because they didn't have all that, in years past when all these horrible things were reported. And in fact, nobody who's been monitored during an MR exam has died. Yeah.
I wanted to ask some questions about your, I was fascinated by your modeling of clinical VT. Were those patients or pigs that you were showing?
So the first set of slides, it said pig, whatever, that number, those were the pig. All the stuff at the end, the last 3 were patients.
Okay, and that last 3 is what I'm talking about.
Yes, those were patients, because those success sites were, our EP colleagues doing the VT ablations. We had no model results at that point.
Okay, on those patients, what was the recording, the clinical recording mechanism? Was it an endocyte balloon that you used to record the electroanatomic map?
No, it was just Cardo.
Okay, so just point by point map.
Yeah, it was just Cardo. I'll go back to that.
And then in the modeling, were you blinded to what the Cardo map showed? Or
Yes,
did you,
yes.
You were?
Yes.
Okay.
Because it's 2 complete labs. One's in the medical center, the other's on the university.
I see.
We don't have quite, our university and medical center are about 5 miles apart.
I see.
So they're and there was no communication as to what was what. So so this, the regular EP attendings, did
I understand.
this, and then the modeling people did that. The only commonality was in fact, these MR images were not even available at the time. When they just did a standard, EP guided, with pace mapping and entrainment mapping to do this. And then the modeling people did not know these results.
So did they know there was more than one circuit? Because one circuit's sort of exceptional. Some of these patients have 3, 4, 5.
They were not told what was going on.
They just a priori with the
Just
model and the scar.
take the anatomical information, segment out the the gray zone, the normal tissue, the scar, put it in the model, run the model, and they would run the model with simulated pacing sites at many different places. Because different pacing sites would actually give you different morphologies of VT. And they typically get 3, 4, 5 different morphologies of VT in the model, which is not too dissimilar from the VTs that we were getting clinically. We actually got more VTs in the model than we got clinically, which actually to me makes a lot of sense, because I think that if you're just inducing, you have a limited number of points you can induce from. We have our standard RV induction points typically, and you might get 2 or 3 or 4 VTs. Where this in the model, you can actually do probably a much more extensive study.
The model was the other thing that struck me. I'm not a modeler, but the fact that you use only cellular physiology to change the model doesn't make any sense to me. That you would manipulate the intracellular currents when a scar has got all this fibrosis, and it's the extracellular behavior that's the problem. You've got less cells generating current. You've got an extracellular matrix that has a completely different resistance. I would think those would be the critical variables.
Right, so what we did So what we did basically, again, I'm not a modeler. I mean, I'm a clinical EP guy that knows a little bit about physics. But so what they did is some of what you're saying, I think, is taken into account in the model, because basically, they used kind of a standard, Dr. Rudy's model, and then this Tin Tusher thing for, I guess, for the cells, and they basically just, Natalia's been doing this kind of modeling of whole hearts for quite some time, and I guess they're looking at electrical propagation, from kind of node to node or from cell to cell, if you will. So basically, I think what's really being changed in the model, I think if you look at it kind of down to brass tacks, is pretty much the conductivity. Because like the SCAR has no conductivity. Because I don't think anybody thinks electricity goes through the scar itself, and then the kind of the normal looking tissue has normal conductivity, and then it's really just what do you do with the conductivity for this kind of gray zone, and basically they just made it an intermediate conductivity, and if you do that only, almost independent of what's happening here, you can actually reproduce this stuff, because what it does is it gives you a slow conduction path. And interestingly, that slow conduction pathway has to be a certain size compared to the scar on the heart, or you don't get VT. In fact, again, Natalia's group was blinded to what we were doing in our pigs and what's happened in the patients. Well, they probably read the literature, but in fact, it took about twice the size of the gray zone, if you will, to be inducible. Because if you made the gray zone critically small enough, like less than about 10%, of the scar area, in fact, it wasn't inducible, even with all this modeling stuff trying to induce in various areas. It's surprisingly similar to what we got, suggesting, in fact, that could be really the mechanism. Yeah.
So some of the non-ischemic cardiomyopathy MRI images that you display don't reflect this, but often in non-ischemic cardiomyopathy there are multiple areas of gray zone. So, to actually use this as a template for ablation would be very difficult. And even in some of the images that you showed, there are other areas of gray zone that did not figure in even the computer modeling.
Right.
How can you use the gray zone really to are you going to ablate everything that you see that's gray?
So that's the $64 question. So I think the modeling proponents would